I have a few questions which I'm sure students have there in their minds. So first question is to Arun. Arun, what is the lowest level of anastomosis which can be done by staple, below which you would say it should be hand sewn?
Sir, again, depends on one surgeon's experience. To begin with, a stapled anastomosis will be something like a low anterior resection. Then, as his experience, the surgeon's experience advances, he can reach to ultra low anterior resection. That means at the level of anorectal junction. Then, with maybe some other years of experience, a partial ISR can be done with staplers.
What I wanted to know that below what level you would say that stapled anastomosis should not be done, it should be hand sewn.
Sir, anything below, if the level of anastomosis is below the dentate line, it should be hand sewn. That means it's a subtotal or total ISR.
But you said that the anorectal ring is at the level of the levator.
Yes.
Now, if I have mobilized the rectum up to the levator, the pelvic floor.
Okay.
Dentate line is below that.
Yes, sir. 2 centimeters
when
below
I fire a stapler, the stapler is going to be fired at the level of the pelvic floor.
Sir, that is for ultra low anterior resection, but we can do some amount of intersphincteric dissection into that plane between the levator ani on one side and external sphincter on the other side and the smooth muscle of colon of the rectum on the other side.
The other question which is frequently asked from the students, and I think partly Rohin has answered that, but again, to give a specific answer, any one of you can take this, that upper rectal tumor, today, how much of mesorectum, how many centimeters below the lowest edge of the tumor you would take the mesorectum?
Me, 5 centimeters.
Utpal?
Yes, 5 centimeters.
Deep?
5 centimeters.
5 centimeters.
So not a complete TME, which was originally described by Field. Okay. Next is, how does the tumor histology, differentiation, mucin, whatever else, decide or dictate the margin?
In my opinion, if it is a very low tumor and you are thinking of doing an ISR or an APR, then I will do an APR if it's a poorly differentiated, if it's mucin secreting or sigma or mucinous adenocarcinoma. If any other tumor, I will use 2 centimeters rule.
No, so even for a well-differentiated tumor, no mucin producing cells, you would take 2 centimeter or you would take 1?
I would try for 2 centimeters. But if I would try for 2 centimeters, if I can't, I may compromise on 1 centimeter.
That is what I'm asking. In order to preserve the sphincter in a
well-differentiated, I may compromise, but I won't compromise with any of the others.
That is what
Even moderately differentiated, I won't compromise.
So, what about neoadjuvant treatment? How much minimum margin you would accept to preserve the sphincter if the patient has received neoadjuvant treatment?
Well differentiated, a negative margin, even 1 millimeter margin, but poorly differentiated, at least 1 centimeter margin, post neoadjuvant.
So what you are saying that if there is no neoadjuvant treatment for poorly differentiated 2 centimeter, with neoadjuvant 1 centimeter?
No, sir. With neoadjuvant, well differentiated, even a negative margin, 1 millimeter margin should be good enough to save the sphincter. But poorly differentiated, we need more margin even after neoadjuvant treatment because chance of local recurrence is high.
I would disagree. If it is well differentiated, even if you have given neoadjuvant, from the fresh margin of the tumor, I will take 1 centimeter. If it's poorly differentiated, I will take 1 centimeter.
Sir,
because
yes.
No, but please, just a minute. You are all talking of 1 millimeter. The moment you are firing...
1 centimeter, not 1 millimeter. I said 1 centimeter.
Arun said 1 millimeter.
He said 1 millimeter. I said 1 centimeter.
Sir, we aim for 1 centimeter, but oncologically, a negative margin is sufficient in a sphincter saving surgery post neoadjuvant.
Yes, so there is a paper from Britain which says a close shave anti-resection is sufficient.
Please, Ramesh, don't go to individual articles. Tell what the student should say in the exam. This
1 centimeter
is not for practicing surgeons. It is for students.
They should say that 1 centimeter should be the minimal margin that they should have after neoadjuvant, whether it's well differentiated or poorly differentiated.
Sir, I think in today's time, patient who has received neoadjuvant treatment, favorable biology, any margin which is negative is acceptable. That is now very well documented, and there is a lot of literature available on that.
Sir,
but obviously,
I am also saying the same thing.
I would like to ask you the question.
Sir,
you have a rectal cancer, and your surgeon gives you no. They must answer this. Will they accept a 1 millimeter margin?
No. What you do in practice is a different thing. This is a teaching session. We have to teach the students what they should be saying.
We teach the student that you do what you would want done to yourself. That is what we teach the teacher. So students, I think that's very important.
So once you are firing a stapler, anyway you are getting 3-4 millimeter margin.
Yes.
Also,
there is no question of 1 millimeter. You are going to get, because obviously you are not going to fire it on the tumor.
Absolutely.
So I think I haven't gone into the finer details, but I think what Deep is saying, that good response to neoadjuvant treatment, well differentiated tumor. I read somewhere 5 millimeter, but it is definitely less than 1 centimeter. If you are aiming for, I mean, what Ramesh said is right. If you can get 2 centimeter, get 2 centimeter.
Absolutely.
If you are not able to get 2 centimeter, even 5 millimeter, and as Arun said, even a clear margin is good enough. Once you are firing stapler, you will get 2-3 millimeter margin anyway.
So can I make
ideally we aim for 1 centimeter and more. But any negative margin is acceptable after neoadjuvant.
This is, as a corollary, I would say when we teach students hepaticojejunosmy, we say get 2.5 centimeter stoma. Now, if you don't have 2.5 centimeter, you can't get 2.5. So you get whatever best you can get.
Sir, one comment regarding a triple anastomosis.
Yes.
The proximal donut is a complete donut with circumference, the entire circumference, whereas the distal donut is only representing a center or a part of it. So a negative distal donut doesn't give sense. I think the negative margin should be in the specimen itself.
Proximal.
That's absolutely true. The donut is of no use. If the donut shows positive, it is of some importance. If it shows negative, it means nothing.
So can I make a comment?
Yes, please.
Just for the technical reasons, sometimes you struggle firing a stapler in a narrow pelvis. The trick at that point of time probably is to use a smaller stapler rather than using a 6 centimeter stapler, and use probably 3 rather than 2 stapler. Also, sometimes problem is of angulation, that, on the right side you are higher and on the left side you are lower. So there you probably need to fire half a stapler on the right side and then adjust your margin. And somebody from the below should be guiding you with the finger that you are almost, becoming transverse with subsequent staplers. That was one.
There is an alternative to this.
Sir.
The alternative is you divide the specimen on the upper end, then you tie a good, strong umbilical cotton tape at the upper end. Then you push a long Kelly's clamp and you through the anus, and you puncture near the upper margin of the specimen. Catch this strongly tied umbilical cotton tape and pull the rectum, everting it out of the anus.
Sir, I would not
the mucosa.
A hole in the.
You will see the mucosa, and you can divide with a stapler very comfortably under vision. I have done this on about 5 occasions, and they were very difficult to do from above and so easy to do from below. Then I just pushed it in and then put the double stapling technique. You can try it. It's a very good technique.
One more, although that was not the topic, but since the experts are here, which is frequently asked of the students in the exam, you have given short course neoadjuvant radiotherapy. Conventionally, we used to say operate within 7 to 10 days. But now there is evidence that waiting longer. So again, what should the students say? That suppose the patient is suitable for short course neoadjuvant radiotherapy, that means it's not a bulky tumor. How long should they wait? And if you are waiting for a longer time, do you add chemotherapy in that way?
You only wait if you are planning to do TNT, as you very rightly said. Otherwise, you still operate within a week.
No,
You're giving short.
I strongly disagree. I think I am the person who has been the strongest proponent of short course radiotherapy for over 25 years. I have been using it for 25 years. And I used to operate it within 1 week, within 5 days, the next Monday after the radiation, like that. But over the last 10 years, we now have sufficient evidence that you must wait for 8 to 10 weeks. What happens, Vinay? And you will not believe this. We have enough cases documented now in our center that if you wait 8 to 10 weeks, the effect of a short course radiation is equivalent to the effect of a long course radiation, and we get almost a complete response.
So do you give chemotherapy in
Yes, we give 2 to 3 cycles of chemotherapy in the
So
intervening.
that's what I'm saying. If you want to give chemotherapy, then wait. If you don't want to give chemotherapy, then
Even if I don't, but I will always wait. Whether I give chemotherapy or not, I will not operate because the tumor will shrink up to 8 to 10 weeks. And if it's a bulky tumor, that's what you want. You want it to shrink. People say that bulky tumors don't shrink with short course RT. They are wrong. The
Rohit,
evidence now is that it does
My
shrink.
take on this, sir. Conventional thing is short course followed by operation after a week. But as per the new protocol, which is the Rapido trial protocol, we give short course, then we wait for 10 weeks, but we give chemotherapy during this 10 weeks.
Absolutely.
And what we
Yes.
found in the Rapido protocol is that up to 32 better short-term outcomes.
Yeah.
However, there's a caveat. The long-term also higher systemic
local
recurrence,
recurrence and systemic failure.
local and systemic recurrence with the Rapido protocol.
Absolutely.
So the Rapido protocol was very famous during COVID, where we gave short course chemotherapy, RT chemotherapy, waited for 10 weeks and then operated. It seemed to have better short-term results, but the caveat is that there might be worse.
That is not completely proved. It is not a statistically significant difference. You know that it's a mild difference, but not statistically significant.
It is significant, sir. It is statistically significant.
No, it is not significant.
Especially distant failure, sir.
Okay,
Distant failures. That is why post this you must continue the chemotherapy. So you must continue, and the short course chemotherapy which we give now is FOLFOX. They were giving capecitabine in the Rapido trial. We are now giving FOLFOX. So our protocol is short course radiotherapy, FOLFOX, 3 cycles, and then operate 8 weeks. to 10
The other question is, how do you decide whether you would give short course or long course chemoradiotherapy? How do you
My decision on my patients is always short course radiotherapy followed by chemotherapy. I do not believe in the long course radiotherapy.
Deep, how do you decide what to do?
A patient where the indication of neoadjuvant treatment is
You're cut off.
We lost. Rohin, what is your
Yes.
practice? How do you decide?
So when the CRM is involved and we want to downstage and make the CRM negative, we would give long course and then wait for 10 weeks for the CRM to become negative. If our aim is to reduce local recurrence because the tumor is T3 or node positive or has EMVI, but the CRM is not positive, then we can give short course. That is what students should answer, I think. There are many caveats to it, but this is a answer for the exam.
Arun,
Our unit follows only conventional long course chemoradiation.
for all cases?
All cases, sir. Any T3N1.
But I think that there is enough evidence now, especially King George Medical College has published a paper where they have shown that short course radiotherapy is very effective. And for a poor country like ours, where patients come from long distance for chemotherapy, for radiotherapy, 5 days of radiotherapy is far more friendly to their pockets and to their relatives than 6 weeks of
I
radiotherapy.
think what Rohin said is very important for students to know. If it is a bulky tumor, you want to reduce the size, downsizing, then most people would give long course chemoradiotherapy.
They give long course because they follow the NCCN
Then you
guidelines.
want to sterilize the margin to reduce local recurrence, where technically the tumor is upfront resectable. Most people would give short course. Whether you
No,
wait
Vinay,
for-
you're wrong.
Whether
You're
you
wrong.
wait for short time or
No,
long
Vinay,
time.
this is
Sir,
the
I
North
joined back.
American.
Sorry. Can I I have joined back. Sorry.
1 second. Vinay, this is the NCCN guidelines. But when you look at the ESMO guidelines, they give short course for everybody, including bulky tumors. Because once you wait for 8 to 10 weeks, even the short course radiotherapy reduces the tumor size. The belief is that long course is more effective. But what happens is that because you've given a high dose in a short time, the effectiveness at 10 weeks is equivalent in
But
both.
still long course chemoradiotherapy is being used. It is not out of the...
No, it is still being used. That's what I'm saying. But ESMO...
That is what I wanted to know. In which case you would give long course?
I would give, even to downstage the tumor, I would give short course. That's what I would say.
That is what you are saying. You are saying there is no place. You are saying there is no place for long course chemoradiotherapy. That is what you are saying.
I'm saying that I don't believe there's a place. I follow the ESMO guidelines.
Don't say what you do. Say what is...
I say I am following ESMO guidelines. That's what I said. European Society of Medical Oncology.
So ESMO says there is no place for long course chemoradiotherapy.
No, yeah, most of them, they don't give long course.
Okay. Deep.
The reason is...
In our practice, short course I will use in a patients where tumor is not bulky. I just want to sterilize my margin. If there's a bulky tumor, I want to downsize, downstage, long course radiation. There is no debate about it, sir.
Okay.
That's what I'm saying. There is no debate depending on what is your point of view. You follow the NCCN guidelines, you do long course. You follow the ESMO guidelines, you give short course. But in a resource-intensive country like ours, where we don't have the resources, I think short course should be used in more and more patients so that we can relieve the radiation.
Sir, there is no evidence at this point of time to suggest that short course is equally effective in downstaging or downsizing.
There is evidence. Not, I am sorry, the Stockholm 3 trial, the Polish 3 trial, the German 3 trial, I'm giving you 3, and the Amsterdam 3 trial, I'm giving you 4 trials. Please read.
I will read, sir, and come back.
I have read. That's why I'm saying.
We are at 8:59. As I said that we start at 7, we close at 9. So I would like to end by...
No, but the students, if they have any questions, you can just finish.
No, those questions have already been addressed on, because they are not on this portal. They are on WhatsApp chat.
Okay.
YouTube chat. So I would like to thank the moderators, Ramesh and Utpal, and the speakers, Arun, Deep, and
Rohit.
And as I said, posted in the chat that yesterday's session already has had 400 plus views. We have very few live students joining because they have the option of watching these videos later. So I don't mind the number. We had about 25 live students, but I'm sure by tomorrow morning or tomorrow evening, we'll have almost same number of views. Some of our previous master classes are now touching almost 1,000 views. So all the 14 master classes have been posted. So students who are watching it on YouTube, please watch the previous master class videos. All the JST videos are online at the Gastro University website. All the Jaipur Surgical Festival presentations are on the same portal. This is a portal which is provided to us by Dr. Avinash Tank. And if you want to read a little more about CA Rectum, please send me a mail, as I have projected in between, vkkapoor.india@gmail.com. Just write rectum in the subject of the mail.
Vinay, I want to congratulate you for doing this academic exercise, bringing such experts like Deep, Rohin, and Arun on the forum, and having differences of opinion so the audience sees that there are multiple ways to manage the patients. I congratulate you for this. It's a very difficult job to do, to organize it regularly and to bring people and to get them to speak. Really wonderful achievement on your.
Thank you. Thank you very much. Thank you, everyone. Good night.
Thank you so much, sir. Thank you.
Thank you, sir.
Good night. Good night.
Good night.